on surgical management of pelvic organ prolapse and stress urinary incontinence, followed by laparoscopic and robotic surgery for the pelvic organ prolapse and stress urinary incontinence. So I welcome ma'am.
Good afternoon, everyone. Okay. Can we have the presentation when you are ready? So while they are getting ready, we can talk about something else. So maybe we have few minutes. So while today we are going to talk about surgical management, so trainees should never think that they need to do all the surgeries or they need to learn all the surgeries. They don't know surgeries, that's why they are trainees. Okay, so nobody should feel ever bad that they don't know this thing or they are not skillful. So I'll give you an example. When I finished my MRCOG all parts, I was at that time I was working in Saudi Arabia as a junior house officer. So junior house officer means just writing histories and writing discharges, not even touching the patients. So I had no surgical exposure and I had no surgical skills, but because I had a lot of time on my hand, so when I went home, I really studied hard. So I went to the UK for a couple of courses and then I went for exams and luckily I passed MRCOG in first attempt. Now think about my situation. I have got the biggest degree and I know nothing. Like I have no surgical exposure because I didn't do any training in Pakistan. So when I went to the UK, then I came back to Saudi after passing my exam, and then from Saudi Arabia, I applied for a job. And the first job I got shortlisted was a clinical fellow in Obs and Gynae, which is like a registrar job in Wales, in North Wales. So I went for the interview, and in interview, they asked there was the whole board in the boardroom, quite a few consultants, directors, everybody was there. So they asked me few questions, theoretical questions, few scenarios. I kept answering. And at the end, I said, can I say something? They said, yes. I said, before you even think about giving me this job, you must know one thing. And they say, what's that? I said, I know nothing. I'm a very risky doctor to employ because I have not even done ever cesarean sections. I don't know how to do instrumental deliveries. I don't even know how to read CTG. So you might think I am MRCOG, but actually I know nothing, and that's the whole idea. I want to come here to get trained, but I don't want you to be in dark. So don't offer me this job if this is not acceptable to you, and I cannot do any on calls alone because I need someone to shadow, so who I can shadow. And they were shocked because people, when they go for interviews, they try to prove that they are the best doctor, their knowledge is best, their skills is best, their CV is best. So everybody went quiet in the room and they said, okay, thank you, and you wait outside. And then after 5 minutes, one of them came and they said, okay, we have decided to offer you the job. And they said, we will give you somebody for 3 months. You will do on calls with them and then you will shadow them. So I stayed in that department for 2 years, and everybody used to make joke of me that nobody has ever done an interview the way you did, that I know nothing, I don't know anything, I don't know cesareans, instrumental deliveries. I have never done this. I know how to take history, how to discharge a patient because I'm a junior house officer. So honesty is really important in whatever we do in life, and that is the only foundation of success. And we should never try to be someone else when we go for an interview. And the easiest thing to remember is the truth. So that always remember, when we are trying to be someone else in the interview, we will make mistakes. And easiest thing to remember is the truth. Always in life, when you are confronting someone, when you are in a court or when you go somewhere, the easiest thing to remember is the truth. So being honest is really important. Okay then, so let's start. I hope you're ready now. Okay. So the reason I told you this story, because all the presentation today is about surgical skills and various surgeries which we are going to discuss. But never to get disheartened if there are some surgeries which you have never heard of, or some surgeries which you don't understand. Because this is a journey. We all have to take this journey. And it is also said that even a journey of 1,000 miles starts with a single step. So this is the first step you all are taking in urogynecology, and you should have faith in yourself. And hopefully this journey will become easier and easier. And there is another quotation that well begun is half done. So if you start something with motivation and honesty, everything gets easier. So let's see what's there in this presentation. So we have been talking about various modalities so far. Conservative management, we have discussed quite a few things like weight reduction, awareness, health education, fluid management, pelvic floor exercises, pessary management, but definitive treatment of pelvic organ prolapse as well as incontinence is surgery. Okay, so the reason we emphasize so much for conservative management, because surgery for prolapse and stress incontinence is not perfect. So at best, the success rate will be 70 to 80%. And if somebody is excellent, maybe 90%. And there are 10% risk of serious complication, okay? And then in total, 20-30% risk of minor to moderate complication. And some of the complications could be irreversible. That's why it's really important to know that it is not perfect. So sometimes we are better off with conservative management. So the problem with the prolapse is that no two patients are same. So one woman can have prolapse in one compartment but may not be symptomatic in that compartment. For example, somebody has a cystocele and she has not much symptoms of cystocele, but actually she has presented to you with stress incontinence. But when you have examined, you have found a cystocele. So she has prolapse, but she is not symptomatic. So that is also a dilemma, what to treat. Whether we treat stress incontinence or do we treat cystocele first. And also, sometimes there are multiple problems. In addition to stress incontinence, there is a rectocele, uterine descent, cervical prolapse, very elongated cervix. So first of all, we need to discuss with the woman what is bothering her most, and then explain everything, the examination findings, and then decide. And also, when we examine the patient on the couch, the degree of prolapse is less. When they are on the table, because of general anesthetic, all ligaments, tendons, and muscles are relaxed. So usually what we find is a lot bigger prolapse than what we expected in outpatient. So how do we choose which surgery? So first of all, what are the things which are affecting her quality of life? Extent of the prolapse, whether she has completed her family, are we going to conserve her fertility like uterine sparing surgery, or are we going to consider hysterectomy first? Is she sexually active or not? That's the most important point, because some of the surgeries like colpoclysis we cannot do if somebody is sexually active. Age of the patient, for example, if very young patient, we need to keep the vagina functional. Fitness for surgery, if somebody has cardiac disease, can she go through surgery, or whether is there any surgery we can do under local anesthetic. Associated incontinence symptoms, women's goals and expectation. Last week, just before I came here, my last theater list, I was so humiliated because one of our own nursing manager, she was there on my list. And I saw her 1 year ago, because in UK it doesn't happen that if you are a member of staff or if you have someone knows you, you will jump the loop. It will not happen. Everybody has to wait the same time. So on the day of surgery, I said, you are coming for a prolapse repair? She said, yes. And I looked at the notes, and it was just posterior repair. I have documented she's coming for a posterior repair. I did her posterior repair. And what happened after surgery, that I got a call from recovery that this patient would like to see me urgently. And I went there and she said, oh, I'm so shocked. You have done my surgery, but I'm still leaking. And I said, what? I did not do any surgery for you to stop leaking. She said, no, that's what I was expecting, that my prolapse will go and my leaking will get better. I said, posterior repair doesn't do that. She said, no, but this is what I wanted, and I'm still leaking, and I wasted such a long wait. And you know, over there people are very upfront. They are very confrontational if their expectations are not. And I felt so humiliated that after spending 11 years in urogynecology, I could not meet her expectations. She was expecting that after her prolapse surgery, her incontinence got better. And maybe I did not clarify this to her. I should have been a bit more clear. There was some breakage of communication, but I really felt humiliated, and I apologized to her. Usually I see patients 3 months for routine follow-up, and I told her I'm going to see you in 6 weeks' time. We'll talk about it and we will see what we can do. But I'm telling you, you may consider me as an experienced urogynecologist, but even in my daily practice, sometimes people can be shocked that their expectations are not met. So women's goals and expectations, that point is really important. Work, physical activity, domestic circumstances, previous management and outcome, and surgical experience and familiarity with different surgical procedures. The last point is really important for the surgeon. Do the procedures you are familiar with. Don't do the procedure which you are completely new or you have never seen, because you will be in trouble, because troubleshooting is really bad in urogynecology. General rule. So we give antibiotic cover, but only one antibiotic shot we give during surgery. We don't give 5 days of antibiotics or 3 days. It is just one antibiotic when we are inducing for general anesthetic or spinal anesthetic. Thromboprophylaxis is the most common one because DVT is a common problem after any pelvic floor surgery. So this is the top of the list. Everybody has Clexane for thromboprophylaxis, and everybody has TED stocking. Do we have TED stocking here? Like special stockings to prevent thromboembolism? Do we have here or? Okay. So they are 100% must there. Even for day case surgery, they have TED stocking, and major surgery, they have to put on those stockings for 6 weeks and 7 days of Clexane. And if they have a risk factor, for example, antiphospholipid syndrome or any other problem, then they have 28 days of Clexane. So we have to discuss route of the surgery, which is vaginal, abdominal, or laparoscopic. Anesthesia we have to discuss. The good news is that a lot of surgeries nowadays I do under local anesthetic, and a lot of things we have moved to outpatient setting, which is really great. Since we started doing colpoclysis under local anesthetic, that has transformed the service for women. And a lot of surgeries are day case surgery. I don't know whether you do vaginal hysterectomies at day case? No. So all of my vaginal hysterectomies we do as day cases. So unless the patient is last on the list, because my list timing is 8 a.m. till 5 p.m. So if I have done her after 3 p.m., then I keep her overnight. But if I have done her before lunchtime, they go home. Everybody goes home same day for all the surgeries. All urogyne surgeries apart from sacrocolpopexy and autologous facial sling. So all surgeries are day cases. Fitness for anesthesia, as we discussed earlier. Bladder care. Because our surgeries are day cases, most of the cases we do not put any catheter. And this also has transformed because it has reduced the risk of urinary tract infection a lot. So after vaginal hysterectomies, we don't put any catheter. We just do in and out catheter at the beginning of surgery, and that's all. Sorry? So no catheter at all, no vaginal packing for any anterior repair, posterior repair, perineoplasty, vaginal hysterectomy. So no catheter, no pack, and these are all day cases. Sorry? Yeah. Yeah, but if you think about it, vagina is not a sterile place. It can't be clean. Yeah, so that's, I think, some things we can learn from each other. Yeah, but all of these surgeries can be done at day cases, which will be so beneficial because we have no beds in hospital to keep the patients in. So all of our laparoscopic abdominal hysterectomies are day cases as well. So all laparoscopic hysterectomies are day cases. So if there is a bladder injury, which then they require catheter for 2 weeks roughly. If patient is unable to void, then, or there is a post-void residual after vaginal hysterectomy, then we put a catheter before they go home. Still they go home with a catheter and they come after 3 days, or we teach them self-catheterization. So self-catheterization is used a lot in the UK, a lot. For all the voiding dysfunction patients, we have a specialist nurse. Her job is just to teach self-catheterization and provide patient a little mirror, and there is a little kit and all the disposable catheters. So if there is bladder injury, it needs a cystogram prior to trial without catheter to ensure healing. So post-operative advice is to avoid heavy lifting, strenuous exercise, prolonged straining. For 3 months, avoid sexual intercourse for 6 to 8 weeks after surgery, and avoid smoking, and manage diabetes, healthy diet. And everybody who has urogyne surgery, without fail, everybody has, we provide them 6 weeks of laxatives. So laxative of choice for all patient, every single patient goes home on docustrate sodium. So just 1 tablet a day. We tell them your stool must be really loose. We don't want any constipation. Any straining, any stitch breaks, then it's a risk of recurrence. So 100% everybody has 6 weeks of DocuSate. Okay, so this is an important document. It is available online. This is called Surgery for Uterine Prolapse Patient Decision Aid. So all the trainees should make a note of this, because this is like nearly 20 pages. So it is for patients to choose that what surgery would they like. There are mention of all types of surgeries, which I'm going to mention anyway. But in this document, it is very, very easy. Lay terminology is used. So we use these 2 documents, surgery for prolapse and surgery for stress incontinence. These nice, and we provide patient in outpatient with this document. We give them all the option, and then we have a phone consultation in 2 weeks' time to see which surgery they would like to choose. So again and again, the NICE says that different treatment options must be discussed with the patient. So different treatment options must be discussed with the patient. We should never assume, oh, we think this is a good option for her. We should never assume. Because you are very lucky here in India, because there is no litigation. Over there, if there is a litigation, everything from the very start, judges will have a look that when the patient came, what options were discussed, whether she was offered conservative management or not. Is it documented that she was offered and she declined? Yeah, so it's really important that all options are given and it is documented why we have chosen the option, what we have chosen. And benefits and risk of each surgical procedure, including changes in urinary bowel and sexual function, must be documented. The risk of recurrence, uncertainties about long-term adverse effect, particularly those involving mesh. So in the UK, if you use mesh for any procedure, the only procedure which is allowed at the moment is abdominal sacrocolpopexy. The patient must have yearly follow-up, lifelong of the patient. Can you believe that? Till that patient is alive, every year we have to give her one follow-up appointment every year. It is such a huge workload. So everybody is reluctant nowadays to use mesh, because then it is the patient is attached to you lifelong. And there is no other mesh which is being used in any gynae practice in the whole UK, or at least England, because in Scotland and Ireland some people have restarted using TVT, which involves a mesh, but in the UK it is illegal. If anybody puts any mesh in the vagina in the form of TVT or anything else, it is a crime and you will go to jail. So it is that extent. So at the moment, nobody is allowed to use any mesh in the vagina. So sacrocolpopexy mesh, you have to get special approval, only then you can use it. Okay, so we are talking about pre-op factors.
Dr. Afshan, what is the reason for lifelong follow-up? Is it because of the erosion by the
Yeah.
mesh for the surrounding area?
10% of the patient where we have used sacrocolpopexy mesh, they can have mesh exposure. In the past, we used to use the term erosion. Now the term is mesh exposure. And obviously, the people who are sexually active, if they have mesh exposure on top of the vagina, they can have dyspareunia to both of them, both partners, and it can cause excessive discharge and bleeding. So because of those,
Sacrohysteropexy.
yeah.
In that case, also lifelong follow-up is essential. Uterus is there. We have not exposed the
No.
mesh anywhere. It was just the
Yeah.
uterus between the
Inner mesh, yeah.
and sacrum, and everything is now retroperitoneal and fibroblast.
And this is the commonest surgery which I do. So for example, in last few years, I have done more than 200. So everybody knows that this is my favorite operation. And it is either for vault prolapse, it is equally good, or if it is for procedentia. Even minor degree, because the way I have tweaked my technique, even asymmetrical prolapse, I do colpoclysis. And the best news is I do it under local anesthetic. So what happens then? Still endometrial thickness was less than 4 millimeter. So she did not need any intervention. So if after colpoclysis, if they need hysterectomy, they have abdominal hysterectomy if they need. So after transvaginal scan, we do MRI if there is any suspicion of thickened endometrium, which is more than 4. And if MRI is normal, then nothing needs to be done. And stress incontinence, so when you are doing colpoclysis, you need to leave at least 3 centimeter area under urethra where your triangle is closing. If you leave less than 3 centimeter, then you have stress incontinence, because then urethra doesn't close properly. There is a traction. So you must leave 3 centimeter under urethra. So your front triangle should be starting a bit low. Yeah. Okay. So what I will do, I will draw a picture in the end to show my simplified technique of colpoclysis. So maybe that will help a lot of patients. Okay, so we are talking about various factors. Now we are talking about incontinence. Whenever we do prolapse surgery, as madam has correctly mentioned, people have risk of incontinence. They didn't have incontinence before, so they have swapped one problem, which is prolapse, with incontinence. And it's terrible, isn't it? They would say at the end, it was better for us to have prolapse than to have incontinence. Why did you do this to me? So you must tell them that this surgery is associated with risk of incontinence, any prolapse surgery. But you need to make your mind clearly, is it worthwhile having the risk of having incontinence? And you also tell them, if prolapse is very bothersome, yes, we can agree to do surgery. And if you develop incontinence, you will need later investigation in the form of urodynamics. And then we can offer you surgery for overactive bladder or stress incontinence. So you give them hope as well that if you develop incontinence, we can do something about it. So that's another thing. Sometimes there is some consultants do concurrent surgery for stress incontinence and prolapse in women who have anterior or apical prolapse and have stress incontinence at the same time. The example of this will be somebody has a cystocele and somebody has stress incontinence. So they have had urodynamics, which has confirmed stress incontinence. So some consultants do anterior repair, and at the end of the anterior repair, in the past, they will put a TVT, or now they will put a sling operation. Yeah? I do not do that. The reason is because all of us who do urogyne surgery know whenever somebody has cystocele and have incontinence, there is 50% chance that just doing a cystocele repair will improve her incontinence. 50% chance, which is very significant. So I always do single surgery. I never do concurrent surgery. Because if patient is lucky, but you must tell them that you have got good 50% chance your incontinence will get better. If it didn't, don't worry. I'll see you in 3 months. We can investigate you and we can offer you surgery for stress incontinence or overactive bladder. But as Dr. Seema was mentioning, Kelly plication and all that at the time of anterior repair. So if you... Yeah. So I heard that is a common practice in India. Okay, if woman's chosen procedure is not available from the consulting surgeon, refer her to an alternate surgeon. This is something of ethical value. For example, in UK, in order to have super specialization in certain procedures, procedures are divided in between colleagues. For example, in our organization, I'm the only consultant who does autologous facial sling. So if any of other urogyne consultants patients has chosen a sling operation, after she is given all the option, that patient will come to me. And I don't do Birch colpo suspension. Just my personal reason, I just don't like the idea of that operation. But when I give my patient the document of surgery for stress incontinence, decision aid, and she has chosen Birch colpo suspension, I send her to my colleague who does it. So it is just ethical practice. So at the end of the day, patient is happy that what she has chosen, she has been provided with. So it is about concurrent surgery. combined procedures, and must thing is a follow-up after surgery. I don't know in India whether it's a regular practice to have a regular follow-up, but in the UK you must have 3 months follow-up because you have to enter this data on British Society of Urogynecology website. Okay, so let's go to traditional anterior repair type of procedure. Nothing special in this slide, and we will see a video in a minute, and that is a nice for junior trainees to have a look. So rather than looking at this description in words, we'll have a look at a little nice video. Okay, so let's have a look. Let's play that little video at the end. So I think it is the one which I'm thinking, if it is on a mannequin. The one on the link is there, yeah. Sorry, it is the link at the bottom of the slide, this one. I hope it is the same one what I'm thinking. Yeah, this is the one.
Patient in dorsal lithotomy, place Foley catheter for recognition of the urethrovesical junction. Use 2 Alice clamps to grasp the vaginal epithelium at the urethrovesical junction and at the vaginal apex. Inject hydrodissection solution subepithelially. I use 20 units of putrescin, 20 cc's plain 0.5% Marcaine in 100 cc's of normal saline mixture. I typically use 20 cc's of mixture for the hydrodissection. With a scalpel, incise the vaginal epithelium between the 2 Alice clamps, from the urethrovesical junction to the apex. Dissect the underlying vaginal muscularis from the epithelium to the margins of the dissection bilaterally. Surgical tips. Place an Alice clamp on the epithelial edge. Using your forefinger as traction, use medicine ball scissors to carefully dissect the fibromuscular layer away. An assistant can maintain traction medially on the underlying muscularis tissue layer with atraumatic pickups. Providing traction and countertraction is very important for a clean dissection. Dissect the underlying vaginal muscularis from the epithelium to the margins of the dissection bilaterally. Delayed absorbable suture. Plicate the prolapsed fibromuscular layer in 1 or 2 mattress layers. Surgical tips. Avoid tension and avoid taking excessively deep bites
trigone and ureteric orifices. If the prolapse is particularly large, consider placing an initial purse string suture. Trim excess vaginal epithelium and re-approximate the vaginal epithelium with 2O or 3O delayed absorbable suture in interrupted, subcuticular, or running fashion. Perform cystoscopy for evaluation of bladder integrity and ureteral patency.
Thank you. We can go back to presentation. All right, so venous plexus bleeding, although she injected quite a generous amount of pitressin, which is vasoconstrictor. If it is not available, we can also use adrenaline solution along with bupivacaine. So benefit of bupivacaine will be because we do it as or day case surgery, so it's not painful for the patient. So I use 0.5% bupivacaine with 1 in 200,000 adrenaline in a total of 20 to 30 mils. And sometimes venous plexus bleeding can happen. Most of the time, if it is a day case surgery, we have to sort that out. We cannot use diathermy too much, so we use 2-O-Vicryl to put stitches rather than using too much diathermy on anterior vaginal wall. Cystoscopy is not a routine in my cases when I do anterior repair, but if I have done very extensive dissection, then I do cystoscopy, but it's not a routine procedure. So if you use a lot of diathermy, there is risk of development of fistula. So we need to try to avoid diathermy in vagina. And again, stress incontinence might be unmasked with correction of urethral kinking associated with vaginal wall prolapse. Okay, so success rate initially when they say 100%, recurrence rate of 40%, 43% was reported. So anterior repair is the one with the highest failure rate in all of the prolapse surgery. And this was the area of my research. So my research paper, what are the reasons why anterior repair fails? So it was a biomechanical study. So we took pieces of the trimmings from anterior vaginal wall from various patients when we did repair surgery, and we analyzed these in the lab to see biomechanical properties of the tissues and amount of collagen, to see later on which patients developed recurrence. And then we compared, so it was period of 3 years, and then we compared what was the collagen quality, quantity of collagen, and bioelastic characteristics, and whether there was any correlation with recurrence. So good news was that there was no correlation. So we cannot blame collagen, that it was collagen or biomechanical elasticity problem. That's why people have recurrence. So this means it is surgical technique. And top of the list is if we do not correct the apical support, anterior prolapse will always fail. Okay, we'll talk about that. Let's go forward. Posterior compartment. So it's exactly same type of technique. The reason it is a busy slide, it's for trainees because you are going to get a soft copy. So these are the surgical steps, but all the experienced people, obviously they do this routinely. The main thing is whenever you do posterior repair, my tip will be do not excise any excess skin. Anterior repair, you can get rid of excess skin, but in posterior vaginal wall, no matter how much loose skin is there, do not trim it, because that is the leading cause of dyspareunia, because then it causes stretching and scarring. So do not trim it, no matter how loose it looks. If you have approximated the fascia underneath, the loose skin will get caught and it will get better with passage of time. So do not trim the skin. And sometimes genital hiatus correction is really important. If genital hiatus is more than 4 centimeters, a tight perineorrhaphy is really important to give support at the end of the posterior repair. So again, bleeding and small bowel injury, fistula, infection, recurrence, these are the risk factors. But the top of the list is dyspareunia, which is usually the result of a tight repair with excessive vaginal narrowing. Women can try lubrication and vaginal dilators, but may eventually need Fenton's repair to correct the narrowing at the introitus. So recurrence rate is 13% to 22%, and bowel dysfunction. So sometimes the obstructive defecation does not get better after posterior repair. Because as we were discussing yesterday, people sometimes need splinting or digitation to empty their bowel. And when we tell them we are doing to do posterior repair, they hope that after posterior repair they will be able to open their bowel easily. It does not happen in every case, because sometimes the etiology of that is rectal intussusception and not the rectocele. So if you have done a good rectocele repair and when you see her for follow-up, the prolapse has completely gone, but the symptoms have not gone, then you will request MRI defecography, and which will diagnose rectorectal intussusception. If you talk to radiologists, it's very easy to do. All they have to do, put some contrast in the rectum, make the patient sit in a commode and do MRI when she is passing it. So it will diagnose intussusception, which can be corrected by colorectal colleagues. So now the next video is about posterior repair. I don't think there is any need to see that. It is similar to what we saw. Unless somebody would like to see posterior repair, I think it will take long time. We'll move on to interesting stuff later on. Okay, so now we are talking about vaginal hysterectomy. Obviously, this is one of the favorite operations what urogynecologists do. Um, but if there is apical weakness, vaginal hysterectomy does not solve the problem. So after vaginal hysterectomy, as Dr. Seema was mentioning yesterday, we must do McCall's scaldoplasty, and there are various techniques which can be done like uterosacral ligament plication, McCall's scaldoplasty, and the technique which I have learned from my teachers, the one I do is a bit different. So I'll talk about that in a minute. It is similar, but it is a bit different. Gives us good result. Again, these steps are for trainees.
In rectocele repair also you do something like
Anchorage suture.
yeah.
Shall I mention that?
Because on the
Yeah, yeah.
LOA position you said is more common, so
Yeah, yeah.
left side fascia is more torn and
Yeah,
goes
yeah.
higher up.
Yeah, yeah.
And you search that and plicate it with
Okay,
the
so let's
vagina.
mention that. That is called, the name of that technique, I have forgotten. It's an Indian consultant in Southampton, and he started that. So he said it should be named after him. He's a nice chap. So, but we just call it anchorage suture. So what we do, once we have done a good dissection and all the fascia is in front of us, let me make a little picture there. So it will be easier.
That step is important.
Oh, I'm impressed you remembered that, Dr. Sima. Okay, so this is our patient. This is urethra, and this is where we are operating. And this is anus, and as you can see. So we have opened up here, yeah? So we have done a lot of dissection. So we have got a fascia now. This is all dissected fascia, like that. And this is the upper margin of the posterior wall. So just think about anterior wall, there is no prolapse, and we can see cervix is there, okay? So we have dissected up till cervix, right in the pouch of Douglas, we have gone there. And what we realized, that one-sided fascia, there is a break there, so there is no attachment. This side is attached there, but there is a break of this fascia. So unless we correct that part, nothing will happen, no matter how good plication we do. So the first stitch after dissection, what we do, we take two vital, we take a bite from here, we take one single bite from there, we tie two knots, not three, in the midline, so this becomes joined like that, and then we take the needle out here in the vagina. We get the needle out here, we take another bite, and we come in the vagina. So what happens? This broken fascia gets attached to the top of the vagina, close to the cervix. So this is the first anchorage suture. Then I'll take one suture here, one here, get out there, one anchorage suture here, one anchorage suture here, one here. So the break of fascia just underneath the cervix, I will lift it up with three anchorage suture. I'll come out in the vagina, go back into the vagina and tie three knots. So one knot there, one there, one there. So this means the break here, which was the reason when the baby says pass through or something, that area, area there was nothing, I have filled that. So that also does a good job for
posterior fornix. So these 3 anchorage suture, they help prevent. And once I have done that, then I do a normal plication, just a normal plication, like that. But at the end, you must, when I do posterior repair, Dr. Seema might remember, I never start with a vertical incision. I always start with a diamond shaped incision from the perineum. No matter whether they need perineorectomy or not, I always start the section. I just make a tiny slither of skin away. I make a rectangle. I remove this triangle, remove this skin. Then I do infiltration and then I start dissecting upward. And when I start suturing, I put these 3 anchorage suture and then I start the plication. So that is just a little tip suturing method. But you should good results. Okay, so now let's go back. Sorry about this busy slide, but I'm sure there is a use for it. Okay, let's go to the next slide. So we are talking about complication. As we know, bleeding can happen, bladder bowel injury, voiding dysfunction, recurrence of prolapse, dyspareunia, conversion to laparotomy. We are talking about vaginal hysterectomy here. Has anyone had any huge hematomas after vaginal hysterectomy or after repair? No?
Long back when I was a PG, I witnessed one case where both the side uterine vessels they slipped, and she was a very old lady,
Hmm.
and she had bilateral broad ligament
Yeah.
hematoma because we used to go for post-operative round in
Hmm.
the evening, the day our consultant used to operate. So when I saw that patient, she was absolutely pale and in shock. And
Hmm.
I had to call that time, lot of phone calls and all, they were not there. So she was attending some function. I ran, I called her there, and then she was operated. So that was only the one
Hmm.
case where I saw
Hmm.
bilateral broad ligament hematoma due to slippage of
Yeah, last year I saw one. It was a retroperitoneal hematoma after vaginal hysterectomy. And the patient's HB dropped by 6 points and she was in shock. But on examination, vaginal examination, there is no hematoma. Pelvic examination, there is no hematoma. Because when it is retroperitoneal, you can't pick it up. So you have to have an MRI scan which confirmed 20 centimeter retroperitoneal hematoma. But most of the time, retroperitoneal hematomas are managed conservatively. You never open them up. So you just give her blood, give tranexamic acid, give antibiotics to prevent infection, and she was perfectly fine in 3 days' time and she went home. So no surgery needed. Okay, so these are the vault hematoma after vaginal hysterectomy is fairly common. If you sorry? Conservative, always conservative, retroperitoneal hematoma. So conservative means you keep checking her hemoglobin every 12 hours, give her 2 units of bloods, keep checking vital signs, give antibiotics, and give tranexamic acid. So mostly retroperitoneal are never open because where are you going to open is tricky. But before that, in order to manage them conservatively, you have an MRI scan before that. That is vital. And it is with contrast to see if there is a spurting vessel or not. So if there is a spurting vessel which is continuous bleeding, then you go and manage it with embolization. Still you don't open them. You do embolization from groin, and then if there is no spurting vessel, you just manage them conservatively.
is the reason, like if infundibulopelvic ligament, from there if the hematoma is forming, that goes retroperitoneal and up, and it is mostly not recognizable from the
Exactly,
bleeding itself.
exactly. Okay, so uterine preservation procedures, as Dr. Seema was mentioning, without hysterectomy we have to manage. So it is fertility preserving surgery, and it also reduces morbidity when we are not removing uterus. Okay, so dissection needing for hysterectomy may cause pelvic neuropathy and disrupt natural supporting attachment to uterosacral ligaments, leading to increased risk of urinary incontinence, prolapse, and sexual dysfunction. So we should never take hysterectomy lightly, and we should try to avoid hysterectomy because uterus does have some function in various ways in bowel and bladder and sexual function. So sacrospinous hysteropexy. So we have a device here, somewhere here. Dr. Shazi, can you pass me through this capio device? That's the one which is open, the opened one. Oh, I got it actually. I remember. So the device which is shown here, I brought one with me. So that's what it is. That's all it is. This is called Capio device. Yeah. So it is Boston Scientific which makes it. So it is self-anchoring device because when you do sacrospinous ligament fixation with Mayer hook or dissection, it's a lot of dissection and it is risky because of neurovascular bundle there and it is a lot of hard work for the surgeon. With this, it is so quick. So what you do, all you need to do, you feel where ischial spines are. Yeah, if very obese patient and you can't feel spine, then you are in trouble. But you need to try to feel the ischial spines and then you start going your dissection on the posterior vaginal wall. You try to go, but actual extent of the hole is only that big because you don't need to see it. You just need to feel it and with your fingertip, you do the dissection. You keep going, you keep cleaning, you keep try to reach the spine. Once you have reached the spine, then your left hand finger, index finger, goes there in the spine and with the right hand, there is a special suture there which is not a needle, it is like a small bullet. So it is like 2-3 millimeter only. So which is capio polypropylene suture. So you can barely see it. I'm sure you can't see, even I can't see. So it's such a small bullet. So what you do, you mount it like that. And now I have mounted it. And the way you check whether you have mounted it well, it should not be pinching on your needle. So it's not pricking me. This means it should go completely in. And there's this thread. This goes in a groove there. So there are 2-3 grooves, one there, one there, one there, and one there. So now you think about it, it's like an arrow, isn't it? So now you are holding it like that with one hand, and this hand is going there where the spine is. For example, ligament is just there. So my finger is on the ligament, and then I go in there because it only needs a small space. This is Capio Slim. Original version is a bit thicker. So I go to the ligament with my finger, I guide my capio that yes, this is the ligament, and then I fire it like that. So what it does, the needle will go through the ligament and the device will bring it back. So it will loop it. And then I take one more. So I take 2 stitches on each side. You can do unilateral, but I usually do bilateral. So I do dissection right side as well as left side. So I put 2 stitches on each side. My theory is that the vagina remains symmetrical. So it is aligned in the midline and it is easy, and then I don't have to put too much tension on 2 stitches because I have 2 on each side. So likelihood of success is higher. So similarly, this I am telling you for vault prolapse. But if there is cervix, when I take the stitch on the sacrospinous ligament, then on the other end of the stitch, there can be a needle, or you take free Mayo needle, you put it in the needle and you take a bite on the back of the cervix. And then you tie it inside vagina because this is not a dissolvable stitch. And then Dr. Seema yesterday beautifully explained how you close it on top of it. So it can be done with the uterine, which is sacrohysteropexy, or sacrospinous hysteropexy, or you do it for vault prolapse, which is sacrospinous ligament fixation. So hematoma is a complication, bowel injury, right buttock pain. So you must write that on the consent form, right buttock pain. Because if it happens, it's quite a bad pain. Luckily, it doesn't happen very common. Just 5% of patient may develop it, and it should get better within 3 months. Small proportion of women, it never gets better, and you have to remove the stitch. I've never removed it, but you need to know theoretically. So when you do sacrospinous ligament fixation, later on people can develop anterior prolapse because now all the traction has gone to the posterior, so anterior prolapse can develop. Similarly, when people have Birch colposuspension, later on they can develop posterior vaginal prolapse. So whenever we disturb one compartment, other compartment can be compromised, and you must counsel patient that this is not the end of the story. So what this slide is discussing, if you avoid hysterectomy, you save a lot of blood and morbidity, quicker recovery, less pain, and RCT is mentioned for trainees to make a note when you have a soft copy of this. Manchester repair. I'm sure you all do this. Yeah, this is one of the beautiful operations which has low morbidity, and I really like it. And I'm sure a lot of people, even trainees, would have seen this. It is done. You have to choose your patient well. It cannot be done when all the uterus is lying in the vagina and you try to do Manchester repair. It is only isolated, elongated cervix. Okay, sometime for some strange reason, cervix does grow in some people. So uterus normally present where it should be present, it is elongated cervix. And the test is you can see the whole cervix outside when you do the speculum. It should not be a globular appearance which you see with the uterine prolapse. So you have identified isolated elongation of the cervix, then it's a good procedure. There is a video there, but I'm sure you all can make a note of this link when you have soft copy and look at this video on YouTube yourself. Sacrohysteropaxy. So again, when we are trying to save the uterus, so we can wrap around the mesh. What mesh do you have in India? What type of mesh you have? Polypropylene, the blue color,
Yeah.
and Y-shaped mesh.
We make it Y shape.
Okay,
It comes in triangular and we make it
okay,
Y
okay,
shape, and according to the distance that we adjust it,
okay.
cut the
So we in the UK we have stopped using polypropylene meshes. We have started using Dynamesh. So it is half the weight of polypropylene mesh, and it comes in the form of Y. So if there are any expired one, I'll bring some next time. So it's quite nice, less risk of erosion or exposure. So abdominal sacrohysteropaxy, we wrap the mesh around cervix, we attach the mesh to cervix, we go through broad ligament, and then we attach the mesh to the anterior longitudinal ligament on front of the sacrum.
Actually, attaching this Y, people have different opinion where to attach this Y.
Exactly. Hmm.
So some people, like what we do it, one side we attach to the uterosacral ligament, the other side we bring medial to uterine. We don't disturb the uterine vessel.
Hmm.
We bring medial to uterine, we pass it through the broad ligament, bring it anteriorly and attach to this
Front of the
area.
cervix, yeah.
So with this, there is very nice pull onto the uterus, and it is well version, yeah.
Yeah.
Uterus is nicely anti-verted, anti-flexed, and the other part, of course, to the anterior ligament of the sacrum at the level of S5, S4, S5, at brim,
Okay.
sacral
So do
bone.
you recommend cesarean?
Yeah,
Okay. So you counsel them very well that
yeah.
they must never try to have a.
Our patient conceived, she had delivered
Okay.
one, and again she is pregnant.
Okay.
Yeah.
That's good.
Cardinal ligament. So I do exactly same, and these two I put a clip on the side here. These long stitches, I attach them to the side. For now, so I can manage them after hysterectomy, whatever I want to do with them. So after that, I take the usual steps and I get rid of the uterus. Now uterus is gone now. So when uterus is gone, that is the point when people do McCall's scaldoplasty. Yeah. So instead of doing McCall's scaldoplasty, I don't do that ever. So now I just close string, and this is my vault now. This has all gone, and I've taken a purse string and I've closed peritoneum. So this is all obliterated, and now what I have got in front of me is vaginal vault. Yeah. So this is vaginal vault, and I have got these 4 stitches. If now you think about it, they are still inside the body, and the vault is here. So now I get a free Mayo needle, which is like that, and there is a hole there. So I put this string in that hole, and I use that needle to come from inside into the vagina, into the vaginal lumen, because at the moment I am outside. So I come in the vaginal lumen. So I have, now this thread will be coming out here. So I have attached my clip here. Now I do the same, and this thread is now coming out here in the vagina.
and I do the same, and now I have got 4 like that. So how does it look now? This is my vault, and I have got a stitch coming out here, 1 stitch here, 1 stitch here, 1 stitch here. So I've got 4. 2 are uterosacral, 2 are cardinal. And now this is my vault. So I just do now anterior repair. This is my anterior repair stitch, and then I close the vault as usual. So this is how it looks at the end. But I feel that, oh my God, it is still lying at the hymen. So what is the point? So now the magic starts. Because what I do now then, I take this stitch and I tie it with this while I'm pushing the vagina to the right foremost. And then I take this stitch and I tie it with this. So knot comes there, and the thing which was sitting at the hymen has gone right up into the right and left cornices. So I don't know whether this technique has been described in textbook or not, but that's the only way I learned doing vaginal hysterectomy. And luckily, our vaginal hysterectomies, the risk of vault prolapse after them is lower. Some patient, of course, they have it, but this is how. Do you understand how does it look?
Yes.
So at the end,
What
just
we do, these ligament, we take internal and external McCalls. In an external McCall, we pass it at the center of the vaginal vault, and later on when we pull it, the whole vault goes up.
So instead of that in the center, we do it on both sides. So it gives more natural anatomy. So upper vagina doesn't get
Routing of vagina is
so it
not
is just
there
normal.
that way.
There is no tension. Once, just think about it. Why did this lady have prolapse? Because the uterosacral ligament, our cardinal ligaments, they became very loose. So now we have made those 2 ligaments very, very tight, and we have pushed them where they belong. So that's what we hope, that there should not be any more entrocele.
Sac has to be dissected and closed.
Yeah, so usually in vaginal hysterectomy, posterior, when we are doing posterior,
Sac is dissected. We are still comfortable in the calls. Afshan, we will be more comfortable with our own old McCalls stitch.
that's perfectly fine as long as you get good results. It doesn't matter what technique we do. Okay, so let's move on. Sacrospinous fixation. Now we have discussed that so extensively so far in this over the course of last few days. So the aim is to fix the vaginal wall to right sacrospinous ligament, avoiding the rectosigmoid on the left side, as Dr. Seema mentioned. But because I do bilateral, so that doesn't bother me, the damaging rectosigmoid. This will maintain a horizontal position of the upper vagina on standing, which will ensure compression and closure of the vagina against pelvic floor muscle. It is reserved to frail patients who cannot undergo extensive surgery for its short duration and low incidence of complication. The most important thing before doing colpoclysis is doing uterine curettage. So if it is an 85 years old lady, and so when I have booked her in the clinic, when I have seen her in the clinic, I will do a pipelle biopsy at the same time in the clinic. If I don't have access to result of transvaginal scan or endometrial thickness, in the clinic I will do a pipelle biopsy. If I do not get any specimen at all, then I'm reassured it is very atrophic endometrium. But if it is very, and then I don't send the specimen if there is nothing. But if I get very bulky curating with pipelle, then I send the specimen and then I see her or give her a phone call after result. But it has never happened so far that somebody will come back with hyperplasia or cancer, because they have crossed the age of the peak of the endometrial cancer. But that is in the clinic. But when even in theater, before I start doing colpoclysis, I always dilate the cervix and do a proper curettage, just in case if I have missed anything. And in case, extremely rarely, if I am getting a lot of bulky curettings and patient is under spinal or general anesthetic, then I do vaginal hysterectomy and then I do colpoclysis, because I don't want to take that risk of bulky curetting in 85 years old that can come back hyperplasia and then I have to go back abdominally. So in that case, everybody with a uterus, before we actually start colpoclysis, we should dilate the cervix and do a curettage. And if any bulky curetting, vaginal hysterectomy should always written on the consent form. So we can do hysterectomy, close vault and do colpoclysis. but normally it is extremely uncommon. So I'll tell my technique there, I'll come and draw it. My own statistics, because we have to keep all the strict record of the couple of hundred patients, so 98% success rate. So 2% failure rate. So which is pretty impressive considering it takes only 45 minutes to do it. So risk of stress incontinence after this surgery. So we offer them post-surgery. We don't offer them any major stress incontinence surgery. We offer them bulking surgery, which is again outpatient surgery. So we put a camera in the urethra and we give Bulkamid, which is a bulking agent, on 4 points in urethra, which reduces the lumen of the urethra much smaller, and stress incontinence gets better. So before we move on, I will just describe how do I do that. So the way I this and this, so you keep suturing. There is no need because there is raw area. We are doing like this only. We are doing like this only.
But we have not taken that much, 3 centimeter.
But very few, it's not very popular with us. I have only done
I think putting a catheter or some tube into the cervix will prevent it from
3 centimeter
like going into the behind the stitch. So when we are stitching it, just put a tube
You can
in
do
the
that. You
cervix.
can do that as well.
On either side are two barrels. Single barrel is converted to double barrel for the drainage purpose.
You can do that as well. I think we are nearly there for this part. This is probably the last slide. We talked about sacrospinous fixation. It is uterosacral ligament suspension. I think this video we should see. This is a good one because this is a bit different. Vaginally we can do when the enterocoel is open and bowel is reduced, and abdominally as well it can be done. So I don't know which clip is it. Can you please I don't know whether it is vaginal. I want to show the abdominal one. You open this and then I'll remember. There are 2 clips actually. The second one, this one. This is with robotic surgery.
I'm Elizabeth Coronado, robotic surgeon, here to talk a little bit today about the uterosacral ligament suspension and best steps to get your best outcome.
It's a quick video.
You're going to need 2O ethibond permanent sutures. The purpose of a uterosacral ligament suspension is really to bring the top of the vagina up higher. You see I've identified the ureter there, peristalsing laterally. I'm going to grab the uterosacral ligament 2 centimeters above the vaginal cuff and put my 2O ethibond suture through it. It's on the first 2 sutures, and then my last 4 knots are simple knots. It's really important as we do this to ensure that the ureter.
So we discussed sacrospinous ligament fixation. We discussed sacrospinous ligament fixation. We discussed uterosacral ligament suspension. We discussed hysteropaxy, and okay. So it's 2 syringes, 1 mil in each syringe. So there is a little scope. Which is very small, just the size of my hand. So this scope only goes into the urethra. We can go in the bladder and have a quick look to make sure everything is normal. So in urethra, we look at the urethral meatus, and the first thing we do, we give local anesthetic. I think we can.
That they seem
Shall
to
we
have
finish it?
some uterine prolapse.
Let's
or
finish
vaginal
this one.
Apex prolapse. This is really going to give them their best outcome.
Sorry?
For patients, if you're suffering with prolapse, you might want to ask your physician that's doing your robotic surgery if they think that a uterosacral ligament suspension is for you. We're going to remove the suture here. That other chromic suture at the bottom was a support stitch that I put into the cup of the vagina. Just as I was doing this, I felt like it needed one more support suture. So we're going to remove all of our sutures through our assistant ports and just review the steps one more time. Remember that the uterosacral ligament suspension will...
Okay. So this is just the anatomy of uterosacral ligament and where to take stitches, but it is mandatory to do cystoscopy after that to see the urine coming out of both ureters, because you can easily kink the ureter in this one. So it's not a simple procedure.
That means cystoscopy is must after uterosacral ligament.
Yeah, it's a must. And if you have any doubt, you can give 2 mils of indigo carmine IV, and then urine becomes blue. Then it's easier to see. Because sometimes when ureter is partially kinked, the jet is slower jet. So you see the jet, but actually it's slower. So you want fast jet, and you can see it clearly if it is indigo carmine blue urine. You know, so anesthetist will give that for you. So then the urine will become blue, and when it comes out with a fast jet, you know it is perfect ureter. But if it is like sluggish jet, then you know it is partially kinked. Okay, sacrocolpopexy we already discussed. So this is recurrent prolapse. We were talking about that we can offer them pessary if it is recurrent prolapse. We should not keep pushing for more prolapse surgery, because recurrent surgery is very difficult because of adhesions and scarring and higher risk of bladder and rectal damage. So if somebody has recurrent prolapse, ask them to lose weight, do exercises, start the journey again. Never ever jump to do recurrent surgery again. Surgery is difficult when it is recurrent surgery. Use of mesh. So in the UK, it is illegal to use any vaginal mesh. As we said, only mesh which is allowed is sacrocolpopexy mesh. So that is the first thing everybody needs to know. So some centers in Scotland and Ireland, they have started to use TVT again, but only they are allowed in research setting. So they have started to do research. So if somebody is sitting here for part 3 exam, you need to know that if a patient role player will say, I only want TVT. So this is one of the stations. When the patient is given instructions, she said, oh, I have done my research. Now only operation I want is just TVT. I don't want anything else. So that is your job to tell her, by law, you cannot do that. You are not allowed to do that, even if she wants it. And even if she says, I accept all the risk and I'll sign it. But if you do it, you will go to jail, because it's illegal in England to use mesh. So that's true. It is a crime, because it will come in body mutilation, because something which has been banned by law. Apart from the situation in Scotland and Ireland where they are using in research setting, so they have got approval from MHRA. So that's why use of mesh is very controversial nowadays.
Means sacrocolpopexy, you are attaching this mesh from the anterior part of the cervix to till the this.
So it's a Y-shaped mesh. So we do dissection on the anterior vaginal wall and posterior vaginal wall. So we put one limb of Y anteriorly, one limb of Y posteriorly, and the stem of the Y to sacrum. Yeah, yeah. Biological graft. So there was a mention from biological graft. So the sling operation which we use for stress incontinence surgery, that is patient's rectus sheath. So now some centers, I know there is one center in South Wales. So that is for vault prolapse. So hysterectomy has been done. So the uterine sacrohysteropexy, you go above through broad ligaments. Bec-
The mesh should be below the medial to
Above. Because below will be ureter, isn't it?
If we are doing sacrohysteropaxy,
Yeah.
like there are two methods.
Yeah.
Either you will go like above the uterine cavity, that means the mesh will come lateral to the uterine cavity. But it is said that once the patient will get conception,
Yeah.
it will stretch out.
Uterine has same.
So
Discussion हुआ है.
it is said
We have discussed that.
हाँ हाँ.
हाँ कि uterine से medial जाना है. Medial.
So maybe what Dr. Shaheen is trying to ascertain that when she becomes pregnant, what happens, because it will not distend that much. Yeah, so the part of the uterus which distends is actually above the internal os. So the mesh is at the level of below internal os, isthmus. So when pregnancy happens, the cervix size remains the same, but everything upward, it grows upwards. So that's why there is not much change to the actual mesh, because uterus grows upwards. Just like when bladder gets filled, there is no change to urethra or trigone. They remain same size, but the bladder fills up upwards. Similarly, uterus also grows upwards. So that's why the mesh is not affected with pregnancy. And people must have cesarean section though. Yeah. Okay, biological grafts. So there are grafts which come from cows or pigs, which can be used, but we don't like using them as well because it's a foreign body. And although they have not been banned completely from the UK practice, but we don't like using any mesh because of the controversy. Why to make your life difficult? The only thing I use is rectus sheath thing, which I use for stress incontinence. We'll mention that. But there is a center in South Wales. So they have started taking allografts from rectus sheath to use it as sacrocolpopexy instead of the mesh. To use the piece of rectus sheath, attach it to top of the vagina and attach it to the sacrum in place of the mesh. So research has been started there because we have been using the similar type of for stress incontinence. So they have started the research. So maybe in future, fascia lata from the thigh, it is more useful, isn't it? Because we can take a lot bigger piece, can be used for sacrocolpopexy.
we did with the rectus sheath, but with the uterus intact, we have attached like after cutting the separating the rectus sheath, we have taken out the rectus sheath from that round ligament and then attached to that anterior part of the cervix.
Yeah,
But it
that's
was not that useful.
okay.
After some times, the prolapse
Hmm.
again
Yeah.
it
Yeah.
won't give much support.
No, because round ligament is very flimsy, isn't it?
If you see the history of different surgery for sacrohysteropexy, these are the older techniques.
Sling,
These are
sling.
older techniques.
Okay.
Rectus sheath, but it is not that
No.
there is a history of surgery for like prolapse, hysterosacropexy. These are the older method, and the most latest is the mesh,
Okay.
current mesh is the
All right.
2021
Yeah.
it
Tea
was
break?
invented.
Is it? We are nearly done. Let's see. Yeah. So these are few cases we can do later on. I think I'm talking too long. No, ma'am, that's good. Okay. Thank you. Let's give this back.
As all the knowledge is corrected, hence we use this platform of the GIAN to connect the knowledge together internationally. And thanks a lot, ma'am, for your clear explanation of for the difficult concepts. And now we will have a tea break for 15 minutes.
Yeah, yeah, but very nice. Very interesting. rectus sheath का अरे स्ट्रेस यूरिनरी इनकॉन्टिनेंस में है कि बायोलॉजिकल ग्राफ्ट रेक्टस शीट से लेते हैं तो स्ट्रेस यूरिनरी इनकॉन्टिनेंस उसमें है प्रोलैप्स में नहीं है
क्लास में है वो ऊपर आ गया क्योंकि टाइम बदल जाएगा।
मैम उसकी लेक्चर्स की बारी कर लूंगी मैं।
ठीक है जी, लेक्चर
हाँ लेक्चर्स की बारी
ये
पर
ये
थोड़ा
हो
सा
सकता है यही है, ये तो ऊपर आ गया ना, उनकी वो सॉर्टेड अलग होगा, हमारी वो सॉर्टेड अलग है। वो जो सीओसी वाले वो दोनों सेम है, बस एक पॉइंट का फर्क है उन दोनों में। वो एक में बीएमआई 22 का है, वो 25 का, बस ये फर्क है दोनों में, 22 वाला चला रहा है। बस अब देख लेना क्या होगा फिर।
क्या करना है? अरे बहुत लंबा अभी कैसे जाने हैं? तलाश करने के
ये क्या है? ये हर बार खोलने हर बार ही आ रहा है क्या, ऐसा है क्या? कोई प्रॉब्लम नहीं होगा कुछ, क्योंकि वो एक्टेड के ऊपर कुछ पता नहीं पड़ रहा है। दो कनेक्शन रेडी आ रहे हैं, एक कनेक्शन रेडी आ रहा है, जीरो कनेक्शन रेडी आ रहा है, फिर जीरो हो जाता है बार बार फिर। आइसक्रीम आ गया। लैग नहीं चलेगा। इनकी बहुत बड़ी पीपीटी आ रही है, क्या बात है। ये अमेरिका छोड़ने से पहले इनकी छोटी पड़ी थी अपडेट नहीं थी इनका तो छोटा सा आ रहा था इनका डिस्प्ले, इनका तो और बड़ा आ रहा है, बड़ी पीपीटी क्यों है भाई। नहीं वो ये नहीं कह रहे कि लेक्चर बराबर नहीं करना, मतलब उसका तो वो मतलब नहीं है ना, वो तो जितने लोगों ने जितनी बार पीपीटी चेंज करी है वो ब्रेक करना है। हाँ वो एक्शन इनके, ये जो नहीं हुआ वो तो नहीं हुआ, जो नहीं हुआ वो तो नहीं हुआ ना। हाँ वो बन गया, 11 काट दोगे, अच्छे अच्छे लेक्चर हुए, 2 ही तो हुए अभी तक, एक ही हुआ ये, तो बस एक इतना हो गया लेक्चर, यहाँ से काट के खत्म एक लेक्चर। तो 11 नहीं तो वो सारे तो मतलब कंफ्यूज है, हमें क्या पता था कि 11 है, तो बस ये भी नहीं पता ना ढंग से वो चल ही नहीं रहा उसके साथ।
मैम को बुला लो क्या?
वो खतरनाक मेरी दादी पाना हमने कभी दिखाया भी नहीं उसको रहने दो उसका भी सही है अब ये लगा मैं दे रहा हूँ ये वाला मत दो ये है और तेरी जरूरत नहीं है
Assalamu alaikum. I welcome you all back from the tea session and we will resume the program. So I request So I request Professor Afshan ma'am to please continue with the lecture.
नहीं वही वाला लेक्चर का कुछ पार्ट रह गया था जो सर्जिकल मैनेजमेंट था ना उसके एंड में स्ट्रेस इनकॉन्टिनेंस का पार्ट रह गया था एंड में जहाँ तक हमने देखा था ना इससे आगे बस यहाँ हाँ यहाँ से इससे भी आगे ये बोटॉक्स हमने डिस्कस कर लिए सॉरी 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 ठीक है वापस जाते जाएं अब एक्चुअली मैं खुद जा सकती हूँ हाँ ठीक ओके नहीं this is a view of the bladder with the scope. This is a needle, Botox needle in the bladder. So yeah, so it is the view of the cystoscope and this is a needle. So a person who is the assistant has got this syringe which is attached to this needle. That is next one. So this is Botox. This is for overactive bladder. Yeah. So we give it to 20 places in the bladder. Yeah. So that is the picture. Just above trigone. So you go just like that, 20 places. Anywhere you can give. So the needle, it is graduated needle. So we put at the level of 5 millimeter. So it goes down 5 millimeter. So when we go in the urothelium, we lift the needle up to make a bleb. So that is the main thing. Okay, so that is the picture of the Botox. And it is done as an outpatient procedure, takes 10 minutes. And then if it works for patient, it can last up to 8-9 months. The initial dose is 100 units. And then second time, we can give bigger dose, 200, and maximum is 300 units. Antibiotic prophylaxis for 5 days is essential. Next one is PTNS, the one which we were mentioning. So that is how the machine looks. Just behind medial malleolus, acupuncture needle, and the battery is there, which patient will sit on the couch for half an hour and it will stimulate posterior tibial nerves. So that is also for overactive bladder. So Botox and this one is for overactive bladder. Next we move to SNS, which is sacral nerve modulation, and 80% success rate. So in the back here in the sacroiliac region, a little cut is made and a battery is inserted at the level of S2 and 3, and this is where the bladder innervation goes there. So this continuously stimulates the sacral nerves, and then it can treat stress, urinary incontinence as well as fecal incontinence. So that's the benefit of it, because sacral nerves goes both to rectum, anus and bladder. So that is 80% successful. But you need to have a specialist service, a specialist nurse who deals with this only, and patient needs to have her contact number all the time if there is any troubleshooting. So now we come to TVT and TOT, which was the previous procedure which we used to do. We don't do it anymore. Bulking agent, which we are going to discuss, colpo suspension, and fascial sling. Fascial sling is the one which is most successful. So TVT was a procedure, maybe you used to do it here. So it was a mesh, so that's why we don't do it in the UK anymore. So it's obsolete since 2018. We have not done it. Fascial sling is the one, so it's an incision on the rectus sheath. So this is an important one. So the size of the incision is just 2 centimeter above pubic symphysis, and size of the incision is just size of my finger. So it is just that big incision, and we go to the rectus sheath. We do not open the abdominal cavity or anything. We just stop on the rectus sheath and we draw 1 centimeter wide and 8 centimeter long slings. Exactly I draw like that with a marker pen. And then I use needle diathermy and I take out that piece of the sling 1 centimeter wide and 8 centimeter long. But before I remove it, on both edges, I put PDS2O sutures on both edges. So you can see the sling at the bottom, and there are 2 stitches PDS2O on both edges. And then from that incision, where I have taken the sling graft, I go on the back of the rectus sheath with my fingers with this movement, and I try to go to retropubic space, and I feel the retropubic space. So I am touching now the back of the pubic symphysis. So then I do this movement. So I separate the bladder from back of the pubic symphysis. So I just slide it, move it like that. So the little flimsy adhesion of bladder from pubic symphysis I separate, because that reduces the chances of injury to the bladder when I put the sling in. Apart from that, we don't do anything abdominally. Okay, so the sling has been detached. As soon as I detach it, I have got a kidney dish full of saline, and I put the sling in this along with this PDS sutures on the end. And that will now stay on the trolley for next few minutes. Then I go vaginally, and I make 1.5 centimeter incision on the anterior vaginal wall under urethra, exactly same way as we do in TVT. Yeah. Then I do a little bit of dissection, and I do tunneling with Mackindo scissors. So I go from that incision. So this is incision. I go on the side, retropubic space like that. And then I do on this side. So I'm making a path where my sling is going to go exactly as TVT used to go. Then I have got a metal trocar, which is exactly same trocar as we did use in TVT, but there is no mesh attached to it. And then on that trocar tip, I attach those PDS stitches which I have put on the side of the sling. And then that trocar goes behind the pubic, retropubic space, and it comes out of my incision. And it will be that much apart, 2 ends of those PDS sutures. So now the sling is sitting at mid-urethra, yeah, and some part has gone retropubic space. But the only thing which is coming out of abdominal incision is those 2 PDS sutures. So what I do now, I adjust the tension by putting Mackindo scissors between urethra and the tape, so it is not too tight. I put it very, very loose, and then those 2 PDS suture ends I tie to each other. So when I tie, I ask my assistant to put 2 fingers underneath my knot, and that is a safety mechanism that I do not tie it very, very tight. So these 2 fingers underneath, and I tie it on top of my assistant's fingers. And then I check again if it has become too tight. With Mackindo scissors, I pull the sling down to make it a bit loose. Yeah. So next step is now to do cystoscopy, because these trocars are metal trocars, just like TVT. So if I have gone through bladder, then I can see these blue PDS stitches in the bladder, isn't it? So I do a cystoscopy, and the lateral wall of the bladder, I have a very good look. And if I have got stitches inside the bladder, not a big deal, not a problem. And then I do cystoscopy before I tie the knots. Okay, so they are still loose. So I remove the sling from that side, and I put it a little bit lateral with the trocar again. But then I do cystoscopy again to make sure that it's not in the bladder. And if it's not in the bladder, then I tie the knots to each other, and then I adjust the tension. Then first I close the vaginal incision, and then I go and close the abdominal incision. So roughly it takes 50 minutes, the whole procedure, and 90% success rate. So these are our own statistics. So we have done roughly 70 slings in last few years. So we are auditing, and most likely it will be presenting in one of the RCOG conferences. Because since the tape was stopped, not many centers do autologous slings. So that's why it's an area of interest in the UK. 10% chance of voiding dysfunction. This means patient can't pass urine at all. It's a big problem, isn't it? So everybody who has sling, before they are coming to theater, our specialist nurse teaches them self-catheterization. And they are provided with disposable self-catheters. And they are told, if at the end of the procedure, when catheter, in this procedure, catheter stays in for 24 hours because there is a lot of edema. So, and also give patient some rest because there are two incisions, abdominal and vaginal. So catheter comes out next day, patient should pass urine, we check with the bladder scan, and if there is retention, not a big problem, patient goes home because she knows how to self-catheterize. So we don't keep her anymore. And it is rare that somebody will need to do self-catheterization. 2-3 patients who have needed, they have needed it only for a month and they got better. But we tell them if you have needed self-catheterization, the likelihood of long-term success rate will be a lot higher. So they don't feel bad. So the complication is avoiding dysfunction, or if the tape is too loose, it doesn't work. If you just think about it, it's a flimsy piece of rectus sheath. If patient's rectus sheath is too flimsy, then it won't make any difference. So you have to tell them failure or any problem in 10% of cases. So that is the sling operation. It is called autologous sling operation. Colbo suspension, this is a picture of the retropubic space. We have gone in with a little bit bigger incision and we have put 3 stitches, permanent stitches, to lift the side wall of the vagina upwards and attach it to the Cooper's ligament. 90% success rate, but 10% voiding difficulty. And the patient can develop posterior prolapse later on because of tension in the anterior wall. Bulking agent, this is the most interesting one because we do it in outpatient. So that is a picture of the bladder and bladder neck, and this is a camera in urethra. So in that camera, there is a channel, there is a needle we put in, and then we inject that little, it says collagen, it's not collagen, it is water-based. It is bulking agent, and we inject on 4 points. So if you think about it, this is urethra, so we inject there, 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 there. So size of the urethra at the end is half. That's all. So it's a mechanical thing. So if you think about it from there, it becomes like that. So it is just a mechanical thing. Success rate is only 60 to 70%. But the beauty of this is if this has not helped you, it will not harm you in any way. This doesn't migrate. This doesn't cause granuloma or doesn't cause any problem. So I think it is something to try before major surgery, no matter what your age is. It can be done under local and takes only 5 minutes to do. So if somebody has mixed incontinence, we define which is the predominant symptom and we treat accordingly. So these are the references for the trainees for all those going for part 3, because there are at least 2 stations on this stress incontinence and prolapse surgery. Thank you very much.
Thanks a lot, ma'am, for sharing such innovative surgical skills with us. Now, may I like to call upon Professor Zahra Mohsin, ma'am, to deliver a talk on urinary tract fistulas.
So thank you so much, Mejabeen. Urinary fistulas, I think we do encounter often. We are not a very high volume center, but we do understand that these fistulas are um, are very, very troublesome. They are not only troublesome to the patient, they are also very troublesome for us. Now, just very basics. Since I'm talking about urinary fistulas, the fistula is named, it's a tract, it's an epithelial tract which is connecting two epithelial organs or hollow structures. So depending upon which 2 organs it's connecting, you name it. So the part, the urinary, since the urinary tract is before the genital tract, it comes first. So you have these various kind of fistulas. I'll try and finish well in time, even before. Now, please remember there are about 1 lakh fistulas which develop in the world every year, which is quite a number. And since we have a lot of home deliveries or deliveries which are being done by DIs, unsupervised, we do encounter these fistulas quite often. The most common ones being vesicovaginal, which according to this particular study says they're about 87.5. Then we have vesicouterine, which constitute about 7.1. And then we have urethrovaginal fistulas, which are 5.4%. And very, very rarely, post-hysterectomy, we can have something like a ureterovaginal fistula or as well. Now, another Indian study which said that the maximum, the most important reason we all know for us still remains obstetric injuries. For us, it is obstructed labor. All of you are doing cases of obstructed labor day in and day out. And that is why, for how long do we leave a catheter if you have very frank signs of obstruction? So one thing I would like to really specify is, if your patient starts leaking, you have to inform the senior most person in your team. Please remember that. Because often we have missed and we have diagnosed fistula 2 to 3 days after she started to leak. So for us still, obstetric injuries, especially obstructed labor, remains an issue. Then of course we have surgical trauma being the next most common. I've never seen a genitourinary fistula due to tuberculosis. I think urologists see this more often. But we do come across fistulas secondary to cancer, and we do come across fistulas secondary to radiation. There are very uncommon causes as well. We were discussing those causes just maybe yesterday when we were looking at those pessaries where a neglected pessary can lead to a fistula. I have never seen one. Now, I think, so the most important, so this is just some data. So the most important part which I would like to talk about is clinical evaluation. We all know that the commonest reason and the commonest symptom that these patients present with is continuous dribbling of urine, right? But sometimes whenever the fistula is very, very small, and especially if it's an iatrogenic injury, the patient may come with discharge. Recently we were evaluating a patient, hysterectomy done somewhere else. The patient only complained of watery discharge. So it's very distressing for the surgeon. So a history is very, very important. And then it also depends upon the kind of fistula that you're dealing with. So vesicouterine fistulas might not present with a continuous kind of dribbling. So we are at present managing this patient who is having hematuria during menstruation. And then she doesn't dribble continuously. Her dribbling is only present when she, soon after menstruation or when she has periods. So history, I think, is very, very important. And then, of course, you have to take a detailed history about labor, where she delivered, who did the cesarean, and everything. Now, another important thing, Munaf, mera video please play kar dijiye, is before we go on to exactly describe examination, I would just like to show you a little video. This is a very recent video. Traumatic fistulas are very, very rare. In my lifetime, I've just seen one. It was a penetrating injury, and we did the surgery. With Professor Sharma was on duty, and we did that repair. Now, this is one fistula that I would really like you to see, because we've had this recently, and I would label it as a traumatic fistula. This patient delivered outside somewhere, and 3 days later, she came back to us saying that she was leaking. And दिखाइएगा,
इस तरफ का सर्वाइकल लिप है ना, दिस इज माय एंटीरियर फॉर्निक्स, ठीक है, और मैं इसके बीच में जा रही हूँ, है ना, दिस इज द प्लेस वेयर आई एम गोइंग बिटवीन द टू. ये देखो आ रहा है ना यूरिन, This. Yeah, I'm feeling the defect here. This is where the defect is. Between.
She's holding the cervical lips, like just like you explore a cervical lip, and the anterior vagina is all gone. So recently we've had 2 cases. A second one where the cervical tear repair was done outside. The patient started to leak and she came back to us with a stitched cervix. It was seen by the residents on duty. She came with PPH. You guys examined her, but you missed the fistula. It was only after she started to leak and then we evaluated her again. 2 days later, we realized that there was a fistula in place. So please remember, traumatic fistulas also, though, I mean, they were a rare entity for me, I think they are becoming a reality with kind of unchecked cesareans that are being done in our center. And this other patient, she was given guarantee by some dai ke normal kara dungi types. So 100% guarantee कि मैं normal करा दूंगी. So you see, it was a very bad cervical tear and it extended. It has 2 similar cases. So by the time we evaluated them, we decided to catheterize them. We have catheterized both these patients, and now we're going to plan their repair subsequently. Now, examination of the fistula is most of the times very straightforward. The kind of fistulas that we see, most of the times whenever we do a perspeculum, the fistula is right there. So you have to see the size of the fistula. You have to see the site, at least in the vagina, you can see that once you're doing a perspeculum. So where is the location? Some people grade it according to size. Anything less than 5 mm is a small fistula. Anything which is over 2.5 is a large fistula. So you have to, so examination for us, whenever we do, and of course you have to do the regular per vaginum examination. But the problem is with the small iatrogenic fistulas. I have dealt with 2 kinds of fistulas. We couldn't see them on a simple PS. The patient was leaking. We couldn't figure out कि वो कहाँ से आ रहा था. So in that case, I feel you are always reading about this particular test, which is the methylene blue test. We keep talking about it to you. We expect you to know it. But I think if you can see the fistula, then you don't have to really do it. But if you can't see it, it's so very small that you cannot figure out कि वो आ कहाँ से रहा है urine. Then I feel it's a fairly good test. Because you put these 3 swabs in the bladder, you fill the bladder with methylene blue, and if it is staining the vagina, or I don't even put a swab for those 2 fistulas, we just did a PS and we could see the drop coming from that one corner. So we knew it was there somewhere. So if you cannot really see, then methylene blue is a fairly good test. Then I feel that, of course, we get all those routine tests done, but I feel the other important investigation in all these patients is a cystoscopy. Very, very relevant. So why are we doing this cystoscopy? We are doing this cystoscopy because we want to see how many fistulas, where they actually are, what is the size, and you can always take help of the urology team. Sometimes you may, before surgery, you can even get this ureteric opening catheterized. And the other important thing that you want to see is how far it is from the ureteric opening. So suppose this thing is very close here and you're doing a vaginal repair. You can take that opening in your stitch line. So you have to do a cystoscopy to see how many, where they are in the trigone, supratrigonal, where the location is, how big it is, and it's going to help you plan your surgery, and how close is this to the ureteric opening. So I'm sure all of you have seen a cystoscopy. We do it pretty often. And this is the fistula that we are going to treat. You can see the ureteric opening is somewhere here. It's not a very good picture. ये हमारे अपने phone में से किसी की है. And this is the fistula. We did this cystoscopy during her periods. So we could see the blood coming out through this very tiny hole. So she's a previous 3 cesarean. Right? So I think cystoscopy these are the 2 investigations I feel which are most useful and which are most commonly used by us. I don't, in my experience, I've never used imaging, but people have described imaging. They have described images from simple cystourograms to CT urogram to MRI, but I don't think this is a uterus. You can see the small fistula. It's a vesicouterine fistula, but I don't think we ever have, at least I've never done any imaging, because most of the fistulas that we treated were only after evaluating them on by methylene blue test. And then another important thing that I would like to highlight is, more than imaging, I feel that whenever we do a cystoscopy, we should evaluate these patients under anesthesia. Because once I have also been stuck, there is this very little fistula, I can hardly see it. And when we do this, we plan a cystoscopy and a evaluation under anesthesia with methylene blue in the bladder. We put the methylene blue in the bladder and we can see a very thin, very minute hole. It was a post-surgery fistula in the area of the vault. So what we did is we probed it with some, वो होते हैं ना जिससे हम लोग probes जो हैं वो हम लोग use करते हैं for recanalization. One of those probes, we probed it with that and it went through. We did a cystoscopy with a probe in place. So the cystoscopy was beautiful. We could see it is a very small fistula, very far away from the ureteric orifice. So we decided to do a vaginal repair. But the problem is that the moment when we took her for the vaginal repair, we thought we'll put in a balloon and we'll pull the Foley's and it'll be there for us to repair. But जब हमने वो डाला and when we tried to kind of pull it down, we realized कि वो तो आ ही नहीं रहा था because of fibrosis. Accessibility was so poor. So that day I learned that if you want to really do a good surgery, you need to really evaluate them well in anesthesia before you decide what approach you're going to use. Although it was a very small fistula, we had planned her for a vaginal, but we should have done an abdominal procedure. Because she did not stop leaking completely. Then she started having some amount of dribbling, which was there off and on. So I won't go into details of surgery. Most of the times we always opt and go in for, yes, conservative management is very, very important. So we can do a conservative management for a small fistula. And it is only deemed fit if the patient presents to you early. They say within 4 to 6 weeks. I feel in 4 weeks it might epithelialize. But if she's coming to you early, then it's okay. We often do that. We just catheterize and we leave her and we send her home. We put in a silicone catheter and then we review her every month. कि भाई सब ठीक चल रहा है. This one of our patients came to us today. So we will now operate on her after 3 months. And the reported success rate of conservative management is about 7 to 15%. So people have also used very minimally invasive procedures for dealing with fistulas. One is electrofulguration, where you have this, just like Madam was showing you a cystoscope. I had a video, but I don't think it's any point seeing the video. You have this thin needle. Now that thin needle, just like she had in her cystoscope, where she was using that needle to put in the bulking agent, that kind of an electrode helps you to dissect out the epithelial or de-epithelialize that fistulous tract. And then you can seal the tract either by something like fibrin, or you can even do PRP. So Shine, we can also do PRP if we ever plan. Shine is doing a lot of PRP. And if you suspect a ureterovaginal fistula where, in spite of putting methylene blue, you do not have any methylene blue coming on into your swabs, and you still find that the swabs are stained with urine, you can go in for stenting if the patient is coming to you very early. But for ureterovaginal fistulas, you have to go in for an abdominal surgery. So surgery, you have to really plan, because it's very, very important to decide when you're going to repair. For most of our cases, we never do a very quick repair. People have done a repair after maybe 2 months, but I have never done a repair, I think, before 2 months. It's 3 months we all give. But radiation fistulas, sometimes post-radiotherapy, if you have a fistula, number one, please always biopsy it. because you should be very sure that the patient doesn't have a malignancy. So it's not a malignant edges. So you have to biopsy the edges. And number two, if you have a fistula, please try and manage it conservatively initially and leave it for at least 20 months. Or some people say at least 12 months. So radiation fistulas, we don't repair immediately. So we all know that radiation causes a lot of end arthritis, just like obstructed labor causes a lot of compression necrosis. Radiation fistulas are because of obliterative end arthritis and subsequent a lot more fibrosis. They are more difficult to repair, so you have to really plan them well. Then, of course, we talked about a very thorough pre-op evaluation, just like I talked about. Do a good evaluation under anesthesia. Do your cystoscopy. You should be very well aware of the site of the fistula. And once you walk into the OT, you should know what you're going to do. So you should have the procedure planned before you really decide on what you're going to do and how you're going to repair, because the first surgery is going to have the best outcome, right? So most of us do a vaginal repair. I think some of you PGs will come across us doing the small fistulas. The abdominal approach is meant for fistulas which are larger, around 4 centimeter, or the fistula is recurrent. It is a failed repair. That, like in my patient, where she is now not continuously dribbling, but she is dribbling off and on, we will plan a abdominal repair now, because I cannot pull it any further. And after that little repair, I'm sure it has become more fibrotic. Then any fistula which involves the urethra or requires ureteric reimplantation, these kind we usually refer. And any fistula which is associated with an RVF or is due to tuberculosis, you have to plan an abdominal repair. We sometimes also can plan both an abdomino-vaginal procedure. Then there are many grafts that are very, very important. I brought in a lot of videos, but I think you can see those videos online as well. So the most important take-home message that I would like to give is, and of course these are the complications of surgery, infection. Tell them that in spite of doing the best, they might have incontinence and some amount of sexual dysfunction. But the most important key message that I would like to convey to my residents is that please, whenever you are evaluating a patient, especially who is having a fistula, first of all, please listen to what she's saying. Like this patient was having leaking and you thought, arey wo to hota hai delivery ke baad types. Just don't neglect it. So just listen to what the patient is saying, right? And then please evaluate her thoroughly in the OT. Don't just do a hodgepodge evaluation anywhere else. Properly evaluate her in the OT, preferably under anesthesia. I feel the entire team should evaluate, do a cystoscopy, see if we can pull, because a small repair, we are putting in a Foley's, pulling and doing a Latsko kind of a repair, that we have to do after we have completely evaluated her. After a complete evaluation, you have to plan her surgery, what procedure, what approach you will take, vaginal, abdominal, whatever, and then plan it only if you feel you are capable of doing it. Otherwise, you have to refer her to a higher center. Thank you so much.
Can I ask? Yes, sure. Add something. Can I have a mic, please? Thank you. Just a quick one about fistula repair. When you are doing secondary fistula repair, like after interval of fistula repair, most of the repairs are excellent repairs, and usually they are successful. But the reason patient keeps leaking is not because of the failure of the repair. What happens when patient has a fistula for a very long time? Because of the continuous leaking, the size of the bladder becomes very small. Because when the bladder is not distended, the size of the bladder from grapefruit size becomes like an egg, as I gave example. So that is the reason of leaking, not the actual fistula repair failing. But we forget about that because as surgeon, we always worry that our repair is going to be failed. Actually, it's not failure of the fistula surgery, it is because of extreme overactive bladder. Because the detrusor capacity, bladder capacity has become very small. So it is a good practice after any fistula repair to start patient on anticholinergic or beta-3 agonist, so that the overactive bladder symptoms will get better. Yeah, no, it is small volume, small volume. Because incontinence is mostly because of overactive bladder type, because of small bladder rather than fistula failure.
So thanks a lot, Zara ma'am. Thanks a lot, Zara ma'am, for such conceptual and informative talk. So may I welcome Professor Tamkeen ma'am to deliver a talk on urinary tract infections.
I'm supposed to strain. Assalamu alaikum and a very good evening to all of you. I have been attending online because it was available on YouTube and enjoying the sessions and the very interesting discussions that have been going on. And it feels great to be here back after almost 9 weeks of not taking a single class and not seeing the faces of my residents and my colleagues. So I'll be talking about UTI, basically lower urinary tract infections. वो दे दीजिए मुझे presenter हाँ. So this is basically the talk is based on these resources. I could not find any recent guidelines from the ACOG, but RCOG had a few recommendations, but again I did not have access to that because I was not coming to the college. So, and any guideline which is more than 10 years, I think it's, in any case, it's redundant. So, we all know, do you all believe that males and females are differently wired? We all believe. So there's a big debate, actually a lot of research, whether it is our brains are differently wired or because we are differently primed right from childhood. But anatomically we are different, that is something very, very evident and very clear, no debate about that. More than 50% of women will have one UTI during their lifetime, and 3 to 5% will have multiple recurrences because of these differences. Prevalence of asymptomatic bacteria is also higher in females, and it increases as they become older, more than 65 years of age. And UTIs are 14 times more frequent in women than in men. We all know the risk factors, that is the anatomical differences and the physiological differences that we undergo. So short urethra, intercourse, use of spermicides, diaphragms, history of previous UTIs in childhood, and underlying conditions like diabetes, they predispose to lower urinary tract infection. Apart from that, vaginal atrophy, pelvic floor relaxation, and hospitalization and systemic illnesses as we grow older. Routine pelvic examinations, surprisingly, I found, are also associated with a high incidence of UTI in the next 7 weeks. Women with pre-existing UTI, structural anomalies, or I already told that, or obstruction, they also carry a higher risk of UTI. And of course, pregnancy and purpurium. So these are two conditions where we are more predisposed because of further anatomical changes that our body and physiological changes like immunosuppression that our body undergoes. Most, apart from that, complicated UTIs are related to hospital, procedures. And sadly, healthcare workers are many a times responsible because they do not follow proper standard infection prevention practices. And please remember, the most important risk factor for bacteriuria is presence of a catheter. We'll come back to that again. So the pathogenesis, of course, it's an interplay between host resistance and the bacterial virulence, certain factors in the bacteria themselves. So they are ascending infections, continuous unidirectional flow of urine prevents, and whenever there is an obstruction or that is inhibited, again the incidence will increase. So there will be a back pressure and collection, you all know, like in pregnancy, we are more predisposed to UTIs. Then IgA that is present in the mucosa helps in preventing lactobacilli. In premenopausal, most of the time it helps. And then urine itself has antibacterial features that suppresses UTI, the pH, the urea concentration, osmolarity, and certain organic acids, they also help in preventing UTIs. Then uropathogenic bacteria, they have special features which help them adhere, grow, and break the resistance of the host or its defenses and facilitate colonization. So E. coli, we all know, if you go back to your micro classes, adhesins like pili and outer membrane proteins enable attachment, whereas Proteus mirabilis, it just swarms and it has certain specific genes which makes it particularly, help it swarm solid areas like catheters. So that is the commonest bacteria that will be isolated. E. coli, of course, is 75 to 95% time it is isolated. Then Klebsiella, Proteus, Staphylococcus, Saprophyticus are there. But the resistance patterns depends upon the location from where we are getting the data. And I tried to, go through the Southeast Asian study, the edition of NOVAX. We were looking at the references. Surprisingly, there was just one reference from our area. So the Southeast Asian edition dealing with UTI of NOVAX also does not talk about what is happening in our part of the world. But yes, I found that among locales which have a very high multi-drug resistant UTIs, one of them is India. Okay. Yeast cells sometimes may be formed apart from the bacteria that are there, and they are normally not found in urine specimen, and they may signify either true infection or just contamination because there is a vaginal infection. This is a whole subject, especially for us Indians. Tuberculosis may also may be the cause for these symptoms in many women. Okay. Then clinical manifestations, we all know the terminology that is used. You have simple cystitis, symptomatic infection limited to the lower urinary tract. And when it becomes highly symptomatic with fever, malaise, and it reaches the upper urinary tract, it is pyelonephritis. Then asymptomatic bacteria is considerable bacteria in a woman with no symptoms. Then uncomplicated UTI is again acute disease in non-pregnant outpatient women without any anatomical abnormality or without any risk factors like HIV or diabetes. Then complicated are urinary infection occurring in a patient of structural or functional abnormality of the genitourinary tract. It causes dysuria, may also cause frequency, urgency, nocturia, and suprapubic discomfort, occasionally mild incontinence and hematuria. Gross hematuria is rare. Commonly, when it is upper urinary tract infection, commonly presents with fever, chills, malaise, flank pains, costovertebral angle tenderness, and nausea and vomiting. These patients may not have signs of acute cystitis. Because of the referred pain pathways that we have been going around for the past 3 days, even simple lower UTI may be accompanied by flank pain and costovertebral angle tenderness. So, however, the rule is that assume that the presence of these symptoms represents upper UTI until proven otherwise, because urosepsis is a dangerous thing. We have seen patients dying within 6 hours going into ARDS and becoming a full-fledged case of urosepsis. A history of vaginal discharge suggests that vaginitis, cervicitis, or PID is responsible for the symptoms of dysuria, and therefore pelvic examination is indicated. Prior STD and multiple sexual partners currently is also important when you are asking for the history. Then the patient appears uncomfortable but is not toxic when it is lower urinary tract infection most of the time. Most adult women with simple lower UTI have suprapubic tenderness. Pelvic examination should be performed to exclude vaginitis, cervicitis, or pelvic tenderness, which suggests PID. Acute urethritis versus cystitis. Urethritis, it is gonorrhea and chlamydia most of the time. They may overlap that of cystitis, including acute dysuria and urinary hesitancy. Fever may be a component of urethritis-related syndromes in certain conditions like Rita's syndrome, but rarely is observed in acute cystitis. Urethral discharge is much more suggestive of urethritis, whereas bladder-related symptoms such as urgency, polyuria, and incomplete voids are more consistent with cystitis as they relate to the inflamed bladder mucosa. So there's a whole list of differential diagnoses. Important is to differentiate between urethritis because the causative organisms are different, so you need to do that. Then apart from that, sometimes there's a bladder pain syndrome when she's especially coming with the recurrent symptoms. Then vaginitis also can be associated with dysuria. Predominant features, you all know the predominant features, the different types of discharges that may be there, and then of course PID. Then occult pyelonephritis has to be ruled out, especially in older age women, because in geriatric age group, they are unable to mount a fever or a WBC response. So you have to be very careful while you're taking the history. Only there'll be some confusion or delirium or those kind of symptoms may be there. And they will just report with, just a fall or something like that. Then postmenopausal may also have experienced senile urethritis. So in addition to burning frequency and urgency, they will also complain of vaginal and vulvar itching and discharge. Physical examination reveals a dry, pale vaginal epithelium and eversion of the urethral mucosa. You have seen it so many times in the OROPDs, which will respond to estrogen. So presumptive diagnosis of UTI is made by history, clinical examination and analysis of urine, and presence of WBC in urine and nitrite positive test positive indicates UTI, lower urinary tract infection, and urine culture is not routinely indicated. Urine testing for leukocyte esterase or nitrite is a rapid and inexpensive method with a sensitivity of 75% and specificity of 82%. It's a good screening test, but women with negative test results and symptoms should still have a urine culture or urine analysis or both performed, because false negative results are common, because this is related to the gram-negative bacteria only. So if it is being colonized with a gram-positive, it will be false, false negative. A positive test suggests a UTI, but a negative test does not rule out. That is the dictum. A urine analysis with positive tests for nitrites, leukocyte esterase, and bacteria is highly suggestive of UTI. So routine microscopic examination is a standard will detect. Okay. Somebody just give me my mobile phone. I'll continue from there. If you don't have the. Acha. So what bacterial count should be taken as positive for UTI, suggestive of UTI? From the postgraduates, you're doing it all the time. 10 to the power 5. Okay? But if it is, the urine specimen has been directly taken from a suprapubic tap, then lower maybe. Or if she's symptomatic, then also a lower count may be taken as positive. Okay? Then the next is urine culture. That is the gold standard for diagnosis. It is not necessary in all cases, and most of the guidelines recommend that for the single episode, she's coming directly to you. Do not wait for the culture, and no need to send the culture sensitivity report. We have to use our resources, in a very intelligent manner, because we are working in a poor resource country. Although not necessary in all cases, the culture, urine culture is performed. When will you perform a urine culture? किन केसेस में रिकमेंडेड होगा? सिंगल एपिसोड में नहीं है, फिर किस में होगा? रिकरेंट है या रिलैप्स सस्पेक्ट कर रहे हैं आप, ठीक है, then it is recommended. ठीक, a bacteria is found and a UTI is suspected, urine culture which, sorry, if bacteria is found and a UTI is suspected, urine culture may be sent. If catheterized patients, or we have already discussed that, otherwise generally okay. The American College of Obs and Gynae, but that is again an old guideline, 2010, recommends that a urine culture is not required for the initial treatment of women with a symptomatic lower urinary tract infection, with pyuria or bacteriuria or both. So you just start treatment, empirical treatment, no need to send or wait. In a UK study, and I have seen many residents making that mistake, even in pregnant ladies. Okay, in a UK study, dipstick diagnosis proved more cost effective than positive midstream urine culture for targeting antibiotic therapy, and this is quoted by the 2010 ACOG guideline. So other findings that you may have sometimes in cases of UTI is that the microscopic hematuria may be there in almost about 50% cases of cystitis, and a low-grade proteinuria may also be detected. So we see so many times, you know, patients admitted, they have proteinuria 1+ with urinary tract infection. Then does anybody know what is sterile pyuria? So I'm sure this is Nishat. I can recognize the voice. So she gets a chocolate. Can you help me? Where is that packet? Okay, please give her one chocolate. So the presence of pus cells, 5 to 8, yeah, clap for her, per high power field of microscopy in the absence of positive urine culture is known as sterile pyuria, which may be due to tuberculosis, renal or bladder calculi, mesh or sutures in the bladder, glomerulonephritis, interstitial cystitis, chlamydia or urea, plasma urethritis, or urinalysis which is done, culture that is sent after you have already started the antibiotics. So culture will be negative, but the pus cells may be there. Okay? So there are also some non-infectious causes of pyuria. When the woman is having persistent pyuria, that is not an indication to give her more courses of antibiotics. So these may be uric acid and hypercalcemic nephropathy, interstitial cystitis, sarcoidosis, polycystic kidney disease, genitourinary malignancy, renal transplant rejection, and any periurethral infections. So how do we send urine for examination? The most important part, we have discussed the investigations and we have discussed that no need for a culture. So do not waste time, money and energy in a culture. Yes. कैसे भेजते हैं सबको पता है, हर वक्त मरीजों को बताते हो, यहाँ पे बताओ तो चॉकलेट मिल जाएगी. Okay. So you have to tell her that do not touch the container or the inside of the cover of the container. What else? She has to retract her labia and not use antiseptics, clean the area, and midstream should be taken. Midstream sample should be taken. If she is menstruating, नहीं करने लगेंगे. ठीक है? So nitrofurantoin, trimethoprim, sulfamethoxazole, and fosfomycin. So why did I put fosfomycin as the third option, not the first? So all of them are first line drugs. You all are using a lot of fosfomycin. Doctor, can you share your the first line that you are using? You people? Nitrofurantoin. Yeah, we are also using nitrofurantoin, both in pregnant and non-pregnant. Yeah. So alternative are beta-lactams or fluoroquinolones. Okay, selection of the agent depends upon the sensitivity, cost, anticipated incidence, and severity of adverse effects and dosing interval. Okay, so fosfomycin is so convenient for the patient. The majority of the patients leave the treatment midway क्योंकि they are relieved of symptoms. And symptoms are relieved almost the start of antibiotic therapy within 7-8 hours or maximum 48 hours. 7 to 10 day therapy was used historically, but now we all know that a shorter duration is enough. Shorter treatments offer the advantage of increased compliance, decreased cost, and reduced adverse effects. Okay. Now, other considerations. Empiric antibiotic selection is determined in part by the local resistance patterns. Beta, because for example, in our part of the world, trimethoprim sulfamethoxazole combination has more than 20%, most of the studies, more than 20% resistance. So that is an indication for not using that. Okay, so beta-lactam antibiotics may be used when other recommended agents cannot be used because of any reason. Fosfomycin nitrofuran should be avoided in suspected early pyelonephritis because they will not work. Because if you know this is not even this is a bacteriostatic. It is not a bactericidal. So for pyelonephritis, it will not work, and maybe you are delaying the treatment. Okay, should be avoided in suspected early pyelonephritis. Limit the use of trimethoprim if the resistance is more than 20%, and fluoroquinolones are reserved for complicated cases. Nitrofurantoin, you all know, we are not going to discuss them in detail. So dose, you all know, 100 milligram BD for 5 days, for 5 days, for 5 days. No need for continuation for 10, 14 days, unless it's a case of a recurrent or there's some other reason that you want to. 79 to 92% initial cure rate is there. Then cotrimoxazole, 79 to 100% clinical cure rate. Okay. Fosfomycin, largely underused, single dose regimen, diarrhea, nausea, headache, 3 gram, we all know the dose, single oral dose. Clinical cure rate was initial studies, they found 91%, but now the later studies have reported a slightly lesser clinical cure rate. So nitrofurantoin is again, yeah. So fluoroquinolones, they have good tissue penetration, and you can use either ciprofloxacin or levofloxacin, and they have a higher risk of systemic effects and should not be considered first treatment. Okay. So I go back to mobile. So now a few, again another question, delaying therapy awaiting culture. What would you do? For example, a patient has come to you and you have sent a culture. So will it make a difference for uncomplicated lower unit tract infection? It will not make. A simple cystitis, you can wait if you think that it is very important that you need a culture for that particular case. Okay. Otherwise, cultures are not needed for most of the time. Okay. Then anti-inflammatory agents, she's saying I am having dysuria, or symptomatic therapy that we are prescribing so many times, urine लाल हो जाएगा, उसको बता रहे होते हैं, pyridium, the local analgesic, मैम बहुत प्रिस्क्राइब करती थी डॉक्टर से क्या जब से हाँ बताइए भाई तो should we give it or not? So they can be given, but I told you that once you start the antibiotic, symptoms we just have to reassure her will subside within 5-7 hours or maximum 48 hours. Okay. So, but if you want, you can give pyridium, but tell her that it is going to cause redness of urine, discoloration of the urine, otherwise she'll be scared unnecessarily. हाँ कुछ बोला कोई? Any questions? तो question पूछने का भी chocolate है. हाँ. अभी आते हैं, आप ही बताइएगा. Okay, this question is for Dr. Dr. Aisha. Oh, I can't see. Sorry, Afshan, sorry. Yeah. Do you prescribe, while you're prescribing, do you use this alkalinization or, acidification of urine? Because earlier, when we were reading Harrison's, good old Harrison's, we used to remember those formulas, ABCL Corporation, I remember, Amitabh Bachchan Corporation. Acidify in antibiotics. यार लाइट नहीं चल रही है अच्छा ये नहीं चल रहा वरना दिख जाता हाँ
रूटीनली यूज नहीं करते लेकिन रूटीनली जो दो नई चीजें यूज करते हैं इस तरह रिकरेंट सिस्टाइटिस लाइक सिम्पटम्स में तो एक है डीमेनोस और एक है मेथिनामीन हिप्यूरेट जो हिप्रेक्स के नाम से आता है.
So I just deleted those two slides because I thought that nobody is using it for our part of the world. Yeah. Yeah.
Like symptoms. So one thing is called methenamine hippurate, जो कि हिप्रेक्स के नाम से आता है. So it's 1 gram tablets twice a day for 3 months. Or D-mannose comes in a sachet or tablet. The dose is exactly same, 1 gram twice a day for 3 months. It is for those people who keep on having recurrent cystitis-like symptoms and would like to have some treatments, but giving antibiotics is more problematic. So we use those rather than
So
any
they work,
alkaline.
the mechanism of action is local.
So it is like an antiseptic, hippurate. Hiprex is like a local antiseptic, but it is very mild and it has no side effects. And D-mannose is a type of glucose which prevents bacteria from growing.
Related to use of pyridium, please do not use it for more than 2 or 3 days. It can cause many side effects, okay? So recurrent 2 or 3 days at the most. Avoid, yeah. So now coming to these two terminologies, recurrent or relapsing UTI. So 2 or more infections in 6 months or 3 in 1 year, but separated by at least 2 weeks or at least documented success of first infection. And then relapse is recurrent infection with the same bacteria within 2 weeks of treatment of the original infection. Okay. So how do you prevent? Dr. Afshan just now told us some strategies. So one is continuous prophylaxis of antibiotics can decrease the risk of recurrent infection by 95%, but puts the patient at risk of side effects and colonization with resistant organisms. This is from Up to Date. There is no definite evidence indicating proper duration of treatment, but most advocate treatment for 6 months or longer. So these are the different antibiotics that you can use, but again there is a risk of those two risks you have to remember. Okay, then some people use post-coital prophylaxis because many women, you must have noticed, they come and say, जब मेरी शौहर से बात होती है उसके बाद मेरे symptoms aggravate हो जाते हैं या reappear हो जाते हैं. So a single dose taken within 2 hours of intercourse should be considered in women whose symptoms seem temporarily related to intercourse. And when we're talking about the hygiene, we have to tell them that once you have had intercourse, it is better to go and void urine. Okay. Then self-treatment of symptomatic urinary tract infection is an alternative to prophylaxis. So most of the time, these women will be able to recognize that it is coming. And most of the time, they are correct in 80% of the cases. So they may start the prophylaxis at that time. So 3 strategies: continuous or post-coital when it has been related to intercourse, and then self-treatment whenever they think that the symptom is coming back. And then, of course, Dr. Afshan has been emphasizing on use of estrogen for the last 3 days. I have noticed that. So that is also improves, normalizes the vaginal flora, increases the prevalence of lactobacilli, and decreases the E. coli colonization. So what do we need? A follow-up. It is not required for uncomplicated single episodes. For patients who had hematuria on initial presentation, repeat analysis after a few weeks following therapy should be done. And if it is persistent hematuria, you need to evaluate them. Persistent or recurrent symptoms, again, need evaluation. And then if symptoms persist in a setting of appropriate antimicrobial therapy, urologic assessment and radiographic imaging to evaluate for anatomical abnormalities should be done. Now, this is something, one of my pet peeves. I'm not going into detail. I think I have already, how much time I have already taken? Exceeded? Half an hour ho gaya? Oh my God. Zakham teacher ho gaya kuch. Okay, so I'll just skip this, only a few questions for you all. Okay, to clear certain, this is something I found very useful. Recurrent uncomplicated urinary tract infections and some interventions that they've discussed. Do we really need to treat asymptomatic bacteria? Do we need to treat them? Why? Why you don't want to support bacteria? Because it is the only culture some people have. So we do not need. In pregnancy, of course, please do not go back with this confusion. It is not, we are not talking about pregnancy. In pregnancy, you have to treat it, but for non-pregnant lady, we don't need to treat it, okay? Then clinicians should not treat it is from those guidelines that I just showed you, okay? Then we have a few more questions. This is again, I found from November 4, 2024, a few questions from this, okay? Role of pharmacotherapy for prevention of UTIs, okay. We already discussed that, isn't it? So let's see what these guidelines say. The clinical review found insufficient quality of evidence to enable a clear recommendation. Pharmacotherapy can be considered for the prevention of UTI in women with recurrent UTIs only. Okay. Role of cranberry juice or supplements in the prevention of UTIs. Anybody? Does it help? Doesn't it helps? But do not use. Very good. Who gave the answer? Okay, one chocolate for her. So it helps, but please do not use in pregnancy. Okay, sufficient quality and quantity of evidence found. No clear recommendation. However, it can be used for non-pregnant, but do not use for pregnant. Okay. Can water intake play a role in prevention of UTIs? Yes, no. So I don't have so many chocolates. So many people are correct. Clinical review found insufficient quality evidence to enable a clear recommendation. Cake. Why?
Because her answers.
अच्छा. ट्रॉपिकल ईस्ट्रोजन का रोल है. यस. ये तो राशिका को दे दो.
Deficient लोगों में है.
प्रोबायोटिक्स. यस नो. सुबोई को दे दो. शी इज फ्रॉम कम्युनिटी मेडिसिन. शी डिड हर डीजीओ फ्रॉम आवर डिपार्टमेंट. कोई ऐसा साइंटिफिक प्रोग्राम नहीं है इसमें सुबोई पूरे टाइम ना बैठती हो. और बैठती ऐसे हैं जैसे हम लोग पहले बचपन में मिलाद शरीफ में बैठते थे ना, बिल्कुल बहुत अकीरा था कि मतलब जैसे बहुत ही कोई स्पिरिचुअल एनलाइटमेंट होने वाला है. वो वाली बिल्कुल इनकी वो होती है सिंसियरिटी. ओके. What is the role of sensitivity and specificity of urine analysis for the diagnosis of UTIs, and when should clinicians order urine culture? I think this is just a repetition. We already discussed that. Okay. These are, I'll put those slides in the group so you will be able to see, compare the sensitivity and specificity of different methods. Okay. What are reasonable empirical treatments? We already discussed that. We will just switch that. What appropriate duration? Again, this is just a repetition, but I want to reinforce that nitrofurantoin 5 days, Cyplin DS 3 days, fluoroquinolones 3 days, oral phosphomycin single dose. Okay. Prevention strategies. Some of the postgraduates here. What prevention strategies for preventing lower genital tract infections? Huh? Hydration, yes. Plenty of fluids. Frequent bladder emptying. Say near to synthetic, because sometimes, it causes so much excoriation of the skin, and then there is a colonization and there is ascending infection. Postcoital bladder emptying and hand washing. Hand washing when? Okay. Which toilet do you prefer? Should we prefer? We are copying, the West's. And now, yeah, because of the knee problems also we are doing. So please, for public toilets, please follow the Indian rules. Squatting is much better if you can do it. The toilet handle can have up to 40,000 germs per square inch. Okay. So in the West, you have these things. Okay. So this is with reference to preventing UTI in residents. What would you like to add? Moments of hand hygiene apart from these. ये तो 5 सब करते हैं. सबको करना चाहिए. So before going to the washroom. and after using the washroom. Okay? Then I think, okay, हाँ भाई. UTI is a common condition involving pain in the, okay. What is important here? Short course antibiotics are highly effective. Prevention strategies can reduce recurrence. UTI in pregnancy, please remember, have potentially adverse effects both for the mother and the baby. Obtain a culture in all pregnant patients with suspected UTI and also screen for asymptomatic bacteriuria and treat for asymptomatic bacteriuria. So just one last few slides, truth or dare. How many of you have catheterized a patient? Okay. So how many of you have washed your hands before wearing your sterile gloves? Truth and dare, बिल्कुल सच सच बात हो रही है, बेबी अजान हुई है, हाँ. तो वो जो स्लाइड मैंने दिखाई थी ना कॉटी की, वो याद रखना. प्लीज प्लीज प्लीज. So I'll not go into the details. Just try to remove, once you have inserted it in a sterile manner, remove it as early as possible. Because risk of infection increases 5% each day, 25% at 1 week, and 100% at 1 month. Zahra kahan chali gayi? Her mother was my guide. I remember she used to do cesarean sections without putting in a catheter because she was so much, she wanted to prevent urinary tract infections. Okay. Okay, so we have antibiotic resistance concerns and stewardship. You remember this famous saying from Osler, one of the first duties of a physician is to educate the masses not to take unnecessary antibiotics. And for us doctors, not to prescribe unnecessary antibiotics for unnecessary durations, okay, in unnecessary, combinations. Piperacillin के साथ metronidazole चलती चली जा रही है, क्यों चलती चली जा रही है, हमें नहीं पता. So, and of course having an antibiogram and looking at it every month from your, this is from the microbiology department, I got it for you people. So thank you very much. I thought this is going to be how you're going to behave in my class, either on your mobiles. This is for the residents, of course. But I think the excitement and enthusiasm of the senior faculty rubbed on to you all. Thank you very much for your very kind interactive session. And I think Nishad deserves a chocolate for, every whole 3 days. She has been asking questions and answering questions. I've been observing on YouTube. Thank you.
One comment, only one comment which is clinically useful. Nowadays, we end up giving nitrofurantoin for all because this is the safer and all that. When we use prophylaxis with nitrofurantoin and it is more than 9 months, in any woman or anybody, we need to remember about lung fibrosis. So even with low dose nitrofurantoin, long-term use, long-term means 9 to 12 months or more, it can cause lung fibrosis. And if we don't know this, obviously, it will be missed. If somebody is on nitrofurantoin more than 1 year and comes with shortness of breath, they are probably developing fibrosis. Exactly.
Success comes to those who dare and act. Thanks, ma'am, for coming even after knee replacement surgery. It was really nice of you. And feedback forms are very important to fill for any program to be successful. So kindly fill the feedback forms.